really talking about amino acid-based formula for cow's milk, protein allergy, or even some other disorders. So when we look at cow's, I don't think we have the right, let me see. Oh yeah, maybe let me, oh it could be, we just have an extra slide in there, don't worry. Okay. Sorry. Yeah, I didn't have this one to start. Okay, so when we look at it at adverse food reactions, the whole area, there's this huge area, as you know, of intolerance, adverse food reaction. So you can kind of put them on one side as food intolerance. These are the child with lactose intolerance. They have a viral infection, those kind of things where it's intolerance, versus the other side where it actually is food allergy. So, and it's something I think globally that is misdiagnosed or overdiagnosed in both fields. So food allergy, I'm going to talk just briefly on the one that we're more familiar with, which is IgE-mediated food allergy. And then the other one, which is a little trickier, which is non-IgE. And then there is conditions which have both. So they have the immune, and then they have the non-IgE-mediated. So again, when you look at IgE-mediated, it's the one we think of. The child could or have anaphylaxis. They react right away. They have like eczema. Where you have the non-IgE, and the non-IgE is mainly the GI symptoms. So they may have what we call proctocolitis. They may have food protein-induced enterocolitis. And then the last one is a combination of eosinophilic disorders, which I think were misdiagnosed for years. So what they are is they are really associated with allergic disease. They have a real severe inflammation of the esophagus and maybe the GI tract. The only way they really can be diagnosed is by endoscopy and looking at the number of eosinophils. But they have both, so they have the immune response plus they have the huge GI response. So they're called mixed. So when we look at IgE, those are common, the reactions occur really quickly. I mean, rarely are they ever beyond an hour. They're a few minutes after the infant or child takes whatever they cannot tolerate. So 2 clinical symptoms which you are required is that when you test, those children have the presence of IgE antibodies. And there's a relationship between the ingestion of food and their symptoms. So you can definitely relate that, the child took a milk-based formula and then had those reactions after that. And a lot of times it's the skin manifestations. There is cases where they don't and they would have the GI, but generally that it is the, urticaria, the flushing, so a lot of times it's a skin one. In older kids, sometimes it's a little different. So what they may have it associated with exercise. They may have it where they have, contact kind of like, it's called like Poland food syndrome. So they have maybe oral allergic reaction. But in infants, it's very common, at least 60% of the case, that they're going to have some skin manifestations. The non-IgE is the one that is such a struggle, and people really, those kids go for a long period of time before they get diagnosed because the onset could be more than 2 hours. So it is, you really can't associate it with what you ate at lunch because it's almost supper time and you're having these reactions. And it can be any symptoms. It can be GI, and that's the most common that they would have is diarrhea, vomiting, GI symptoms. But also they can get atopic dermatitis with it. So because it's not easily associated with the food, that's why this one, it's more difficult to diagnose. And it's really based on history. So you look at reoccurrence. When you have these children that have had these symptoms, then you come back and start, really questioning the parents. When did this happen last time? What did they eat last time? What were the symptoms? And that's how you go. So the two main things that we look at are called FPIEs, or food protein induced enterocolitis, or food protein induced proctocolitis. Then there's a one that we talked about, and I use eosinophilic esophagitis as, or EOE as a prime example. And you have the IgE response, but you also have the GI response. So you can have the cutaneous part where you have the skin problems and the flushing, but you also have blood in the stool, you can have diarrhea, you can have malabsorption. And again, the diagnosis, at least of EOE, is really by looking how many eosinophils are in the field when they actually scope them. It's really hard to diagnose without that. So when we look at, although an amino acid based formula can be used for protein maldigestion, malabsorption, children that have decreased absorptive surfaces, eosinophilic, a large amount of the use of this is children with severe food allergies. So, intolerance, you can use other formulas that may be low in lactose and partially hydrolyzed protein. But when you have a food allergy, you really need either an extensively hydrolyzed formula, which is not available here at all, or amino acid based formulas. And children that are more severe, even in US or where they have both formulas available, children that really have severe allergies, a lot of times clinicians will say, let's use an amino acid based formula because our chances of any reaction at all are less, or basically nil. So again, it's nutritionally complete. It's designed the same way as an infant formula would be, so that it has, the amount of protein, fat, carbohydrate, all the vitamins and minerals. It's 100% amino acid based. And now these formulas, when they're amino acids, they're not derived, let's say, from milk or soy or a protein source. They're individual amino acids that are either chemically synthesized and purified, or they're from bacterial fermentation that produce amino acids. So they are pure amino acids that are in the formula. So it doesn't contain all the other allergens that would be there, like milk, soy, fructose, galactose, gluten. Hypoallergenic, and I'll talk a little bit about it later. Again, we make sure, not only have we studied it to make sure it's hypoallergenic in cow's milk allergy children, but every batch is tested to make sure it has no presence of soy, casein, whey, because these products still are made in a plant that on the other side of the plant they make products that have milk protein. So we do both ELISA testing and page testing on each batch to make sure that there's no contamination at all left. Because they're used also for children that may have protein maldigestion and protein malabsorption, 1/3 of the fat blend is medium chain triglycerides. We have DHA and ARA, of course, added, and they're halal and they contain kosher ingredients. Now the protein features, where ours is a little different than, let's say, some of our other competitor products, is we have slightly higher protein content. And I'll talk about that a bit later. Also clinically proven to be hypoallergenic. We also have worked hard. These formulas, if you've ever tasted them, aren't actually tasty to us if we haven't had them since birth. So we have changed the source of aspartic acid and glutamic acid to be asparagine and glutamine, so they don't have quite as bitter of a taste. But when we talk about taste, people worry about these, but infants or any children under 1 year, they get used to the taste of these amino acid based formulas. I always would tell mothers, no infant will starve. Have patience, but they will get used to the taste, and if they've had it from a young age. Again, the carbohydrate, it's not lactose, of course, it is like glucose polymers. And then the fat, has 1/3 of the fat that has a medium chain triglycerides. So why do we have slightly higher protein? And part of the reason for that is that research has shown us that when your protein source is pure amino acids, you don't have the same protein deposition as you do when you have intact protein. So both for our metabolic formulas and for this, where the protein source is pure amino acid, we know that you need slightly higher amounts of protein. Studies have been done with like animal studies that when they compared like free amino acids with intact or even partially hydrolyzed protein, they had less body weight gain, they had lower body nitrogen. Again, adult patients, the same was shown. And also in children, when we looked at PKU patients with those compared to taking their protein as intact protein compared to amino acids, that really height Z-scores and body nitrogen were, you needed to have slightly higher protein when it was as pure amino acids. So also the recommendation is slightly higher, like maybe 30% higher in subjects who the main part of their diet is pure amino acids. I won't go into a lot of details on the studies, but we have done infant growth studies, we've done hypoallergenicity studies, we've looked at protein sensitive colitis in infants, so the non-IgE type mediated conditions, also children that have chronic diarrhea. So just for infant growth, part of it, when you market a formula in the US or Canada, you have to prove that those children on your special formula will grow the same as the gold standard as a breastfed infant. So when we looked at this, we follow them for 4 months and we confirm that they have similar growth, tolerance. We looked at protein status as well. We looked at albumin, and we look at number of stools that these children have to make sure that they have normal growth. So the growth was these, we had to compare to an extensively hydrolyzed, because at that time there wasn't another amino acid based formula on the market. You compare to another formula that's similar to make sure that you have adequate growth. So hypoallergenicity is another one, and these studies take forever to do because there's a lot of children that are suspected or probably do have cow's milk allergy, but they don't go through the double-blind placebo challenge food challenge. But to prove hypoallergenicity, actually it's in the American Academy of Pediatrics recommendation, is that you have to make sure that you have no reaction in at least 90% of these confirmed cow's milk allergy patients with greater than a 95% confidence. So these studies take a while because there's not that many children that really have gone through all the extensive testing. So, and it's also an interesting feature in the field where you really can ask questions, because there's confusion sometimes because formulas may be called hypoallergenic, and you really want to find out, are they truly hypoallergenic? Because sometimes they will call a plant-based product hypoallergenic. Well, we don't know whether it's hypoallergenic or not if it hasn't gone through the rigorous testing. So the World Health Organization, DRACMA, the guidelines for allergy, are really trying to push that we need to put stricter standards on all the formulas so that they make sure that these formulas meet those standards. Then with protein-sensitive colitis, and these were children that were presumed to have like this food protein-induced proctocolitis. They were under 6 months of age and they were fed for like a period of about 2 months. A number of stools really decreased, but also the physicians reported that their symptoms actually resolved as well. So it diminished symptoms when these children had this protein-sensitive colitis. Then chronic diarrhea. So chronic diarrhea, this was looking at the efficacy. Does it support growth, and also does it improve symptoms? So to be in the study, they had to have chronic diarrhea for at least 2 weeks, had to have well over 4 stools per day. And the enrollment was, the mean age was about 3.5 months. The common diagnosis, though, was interesting, was food allergy, but a lot of them had the non-IgE food allergy, where they had the GI symptoms. And no subjects were on TPN in this part of the infants. So the children, they enrolled in the child part of it, they were about 6 years old. And with those ones in the children, they were ones with decreased absorptive capacity because they had GI surgery and had short bowel syndrome. And 5 of those subjects were on total parenteral nutrition. And it showed that they really did, by putting them on an amino acid base, it really decreased the symptoms. Also, the children that were dependent on TPN, 4 out of 5 decreased their dependence on total parenteral nutrition. And I'll end it there. Questions? Do you see a lot of food allergy? Mm-hmm.
Hi. We have here a team for food allergy here. Anyway, so just one question about it. We sometimes face the non-IgE symptoms, and we sometimes face the IgE symptoms.
Right.
Which would be more severe? Because most of them puzzled us in the first.
Yeah. What I've heard from people in the field, they think the non-IgE is more severe because people don't recognize it, right? So even though you can have anaphylaxis, the thinking before was IgE is way more. You're going to have anaphylaxis, you're going to have a problem. But usually, let's say in an infant, you're not going to have anaphylaxis at first, right? And you diagnose them, so treatment-wise, you're usually cognizant, and mothers are careful that they avoid things. Non-IgE, they don't know that they have it, so what can happen? Some of those have been shown to have shock and other things, just because it's not diagnosed. If it's diagnosed, IgE is probably worse than non-IgE, but the problem with non-IgE is the diagnosis may not be there, and so they end up, taking, let's say, a larger amount of foods that may have the problem or the allergen. Yeah.
What do you think about the skin test for the different
Well,
allergy or rust test? Because these things are still being used now.
Yeah. They say, gold standard actually is a placebo-controlled food challenge, because you get lots of both false negative and false positive with skin testing. So skin testing is one way to do it, but really it may not be the best. They really say standards when you really want to do it is the food challenge in a center that knows what they're doing and they can control it. But when you think of it from a practical point of view, it's not. It's not done that often because it is so hard to do. So you have, let's say, an infant that has cow's milk allergy, and you're pretty sure how they respond to it, right? Especially, let's say, if it's a breastfed infant and you realize they're even having symptoms. You avoid the dairy products in the mother's diet, but they still have issues. So you keep them, and you have them milk restricted. They resolve, right? Most children grow out of their allergy. So at that point, sometimes then parents say, well, maybe I'll do some testing then, because if they're from a highly atopic family, is this child going to be also allergic to other foods? But a lot of times it's based on clinical and the testing. And challenges, I don't know, when we look in the US, and that's a very developed market, even then there's only a few centers that do the double-blind challenge with them. Lots still do skin testing, but a lot of times skin testing in a highly atopic child will show you that their sensitivity to pollen, to dust, to mice, to they have a response to everything. So, you know, you can't keep the infant in a bubble,
Exactly.
right? So what do you do?
I think more than 20 years ago,
Right.
they tried to cancel the skin testing and even the last test for the allergy and IgE. I have a lot of discussion about this point when I was in UK, and they don't consider it. But
Yeah.
here,
Still it's being done.
It's still being done
and
here.
It's very expensive.
Yeah.
And it is written like that. So I don't usually get the proper symptoms, proper signs, the documentation.
Yeah.
Okay.
So high index of suspicion. High index. High index of suspicion.
High index of suspicion. You diagnose based on high index of
The
suspicion.
high index of suspicion will be the solution.
So, I mean, still you want to make sure you're not restricting a child if you don't have to restrict a child, right? So when you look at it, let's say you have two atopic parents. One has hay fever, one has asthma. Well, when you get a child then and they're having issues, you're looking at a child that has a 50% chance or more of having allergies, right? So if you have a high suspicion, I still would recommend normal feeding until you actually diagnose it, right? So if the mother's breastfeeding and the child can tolerate it, great. If the mother's not breastfeeding and they don't, try eliminating dairy products from the mother. Will they do it? If they can't, well then you need to go to, let's say, amino acid base. But it should, like, and we have a lot of their centers which will put children from atopic families on these specialized expensive formulas, and you don't know whether the child has it. So you look at it, if you don't have it with double blind, you're looking at what's the clinical symptoms, what's the family history, and then you have a pretty good idea whether the child does. You just don't know after that, is this a child that also is going to have allergens to other foods or other things when they come from a high-risk family. But I wouldn't ever over-treat, because if you don't have to.
Sometimes with these children that they come to us and they have been put on elimination diet of almost every food that I think
I
about.
know.
And definitely this affects growth.
Right. So that's one of the things that's a very good point. With these children, what parents tend to do, or even healthcare professionals, is they eliminate all these foods for their diet. So these kids don't grow well. There's been good studies showing height, weight is lower, BMI is lower. They have nutritional deficiencies because they're not taking all the foods that they need. So, I mean, elimination diets to me are horrid. I mean, just because you can't actually meet nutritional needs. I mean, if you have children that are really restricted, that's when you do need something like an amino acid-based diet, because you're not going to meet the nutritional needs by eliminating